Hello and welcome to MD Newsline. Thank you so much for joining us. Please introduce yourself to our audience.
Thank you, Esther, for having me. My name is Dr. Alice Edwards. I am a pediatric and adult neurology and neuroimmunology specialist. I mostly focus on multiple sclerosis.
Perfect. And I know you work with both pediatric patients and adult patients. Pediatric patients aren't something that we cover often, so I'm really interested to find out what it's like working with pediatric patients with these neurological diseases. How do they differ a little bit from the adult patients in how the disease presents?
It's very rewarding. I love working with kids. I've always liked working with kids. One thing that focusing mostly on the neurological aspects. The brain is quite plastic, so mostly younger patients tend to recover from brain injuries better or most of the time fully, really, and that gives us encouragement and on why we do, and it's satisfying for both the physicians and the patients we care for.
hmm And then as far as how things like MS present in those patients, what differences do you see between those two populations?
Yeah, pediatric patients, like we know, and being a child, as you know, you're younger. And the younger you are, diagnosis, that just means you get to carry this disease for longer. Fortunately, we still do not have a cure, but we have a lot of medications that can modulate and modify the disease course of our patients. Um, Having said that, they present in a more inflammatory way, and I should probably define inflammation. MS is a disorder that affects the brain in a sense that it makes it your immune system attacks the brain, and this tends to happen in present by neurological symptoms that can either occur mostly as a relapse, and these relapses or clinical attacks tend to happen more frequently in children, and so compared to having been diagnosed much later as an adult.
Mm. Yeah, so let's talk a little bit about some of the diagnostic challenges across age groups. So, how do the McDonald criteria for MS diagnosis differ in applicability between pediatric and adult populations?
Yeah. Um, we have our by we I mean the pediatric population has its own McDonald's criteria, and was revised in 2017. The adult diagnostic criteria for MS was just revised in 2024, and it's coming out of publication really soon. Are there differences? Mostly in a way to the diagnostic criteria for pediatric patients incorporates almost all the things that we look at for adult MS, dissemination in time, dissemination in space, and that has just changed in what we look for. We have clinical symptoms. We also have paraclinical presentations. We now include optic nerve. We now include imaging factors like paramagnetic rim lesions, central vein signs. All these things do help us in the diagnosis. But as far as the diagnostic criteria for pediatric patients in itself, we mostly focus on other diseases that can also present like MS and making sure that we're not missing those. Just like I should probably backtrack and say how rare MS is just in the general population, but pediatric MS is also much, much rarer. So in a sense, there are other diseases that can present, especially systemic inflammatory diseases that sometimes affect the brain, are more common. More other kind of demyelinating diseases that we have biomarkers for, such as MOGAD. So those are the one. Pediatric patients are more susceptible to getting encephalitis and meningitis. So there are things by that I mean infections, and we don't want to miss those. So the diagnostic criteria for peds, I would say, focuses mostly on making sure we have the correct diagnosis, but we're not missing other things.
Mhm.
And I will backtrack and say that we have a diagnostic criteria because we do not have a biomarker. There isn't a single test that I can do, whether it's in blood or in CSF, the cerebrospinal fluid, that would tell me whether a patient has multiple sclerosis versus not.
Mm. What are some of the red flags that suggest a non-MS demyelinating etiology in children versus adults, and how does that influence your initial workup?
Right. So how does MS present? It presents as a subacute neurological symptom. By that I mean it can occur within a couple of hours, but symptoms tend to be present for more than a couple of hours. They don't come and go away. In that case, we're thinking something more like a stroke. But they're persistent. They tend to be multifocal because of where the lesions are, multiple. Sclerosis just so the presentation is usually dependent at that time on the inflammatory response. There's usually some edema, so there's some mass effect. And they usually they're classical symptoms that they can present with, purely based on some of the areas that we think we know MS is attacks, mostly white matter. So that would affect your eye. So optic neuritis can affect your spinal cord. They can present with myelitis. Other many diseases can present the same way, but we want to make sure that their presentation meets that. Now, also what MS looks like on imaging has its own characteristics that's very different than many other diseases. And it's hard to describe, but for those of us who do it, I can just look at MRI and say that's MS before having met the patient. But, and sorry, was there a second part to the question? How different it
How
is?
does it influence the workup?
How
What red flags suggest a non-MS demyelinating etiology
right?
versus in children versus
This is MS.
adults?
Okay. So I was first describing how
Mhm.
MS presents. So first things first is the clinical presentation, and it's multifocal, and it has to be more than one attack, or a clinical presentation with the paraclinical features, whether on MRI, and sometimes we use cerebrospinal fluid. Main things for us you don't want to miss. So if a patient comes in with a fever, and some demyelinating or neuroimmunological disorders, including ADEM, sorry, can present with a fever, but the fever almost always means infection. So let's make sure we're not missing meningitis. Alteration in mental status. It's not something we see typically in multiple sclerosis. Again, the lesions, yes, the symptoms come from where the lesions are and the inflammatory response. But at the same time, I don't expect a true cerebral inflammation that I see in encephalitis, where a patient would come in altered and confused and seizing, and that's not a typical presentation for MS. Age group. So this is where the hormonal question had come in, but MS diagnosis, for those of us who use a criteria because we don't have a biomarker, there's a population. When I'm seeing a patient between the ages of 18 and 45, I can listen to their story and be able to tell them they have MS just purely based on clinical presentation in my exam. If I am seeing a 5-year-old with the same exact story, I will never be able to make that diagnosis purely based on my exam and clinical, because it doesn't make sense in a 5-year-old unless it's the only thing that makes sense. So there's a lot of exclusion of other things. I'm trying to think of other red flags. And sometimes it's systemic illnesses that we don't know. One other thing I didn't want to miss: leukodystrophy and I would genetic disorders of the immune system that now we know can also affect the brain, and they're usually intrinsic, innate immune disorders, and sometimes, and this is where genetic analysis becomes important, and these patients, but by the time you're doing this, they haven't met diagnostic criteria for MS because they usually don't look like MS. But yeah, there's a lot of genetic mimics out there.
When I think about parents advocating for their kids, it seems like the road to an actual MS diagnosis can be a bit long, and because it's rare, right? There might be is there often missed opportunities for diagnosis that are
There's
happening,
lots.
and what should parents be thinking about when their kids are presenting with certain symptoms and they want to advocate to say, let's make sure it's not this? Is there an opportunity for them to do that, or is it mostly on the side of maybe the general practitioner type thing? What do you think?
Oh, it's definitely not on the forefront of most general practitioners. Will they be late to diagnosis? Yes, which is why there are very few of us, and there most of us at tertiary care centers, and it's good but there are few of those places, and most of our patients can't get there, and so um, unfortunately, yes, there. I guess we as pediatricians we tend to know how to I'll rephrase. We trust parents. um and if a parent is coming to you and really saying this doesn't make sense and we've done ABC and I don't have an answer, then I think um we have to listen to them. And sometimes it's getting an MRI in a child should not be so hard. And it isn't, except for the fact that in a community hospital, they'll say, oh, you need anesthesia, oh, we need this. Uh, and half the time the MRIs are broken or not available. Um, we need education for the general practitioner. But at the same time, there are other diseases that I also don't want them to miss, because MS is really, um, a child isn't going to die of MS, which is great, but they will die of all the other things I just mentioned.
Yeah.
So I want them to get to me, yes, so I can treat them and help them grow and prevent relapses. But I want that stuff taken care of first.
How does the accelerated relapse rate in pediatric MS inform early treatment escalation compared to adult onset disease?
Right. It's funny the way you phrase the question, early treatment escalation. That's the problem. We don't do escalation anymore, especially in pediatric patients. They're hyperinflammatory. They need the drug that would work the best, the fastest. Um, but the high efficacy you go, you're trading side effects. Um, and I will backtrack by saying we work, most docs out there, the general public, we work by FDA recommendations, and we only have one FDA approved medication for pediatric MS care. Why is that? It's how we design trials.
Mm.
Um, it's how the ethics of it. And we know we have medications that work very well. How am I going to put my patient in a comparator trial? That's hard. There's a different way of doing these trials, which is essentially what we have done. Most MS physicians who treat pediatric patients, we use adult MS drugs. We use pharmacokinetics and pharmacodynamics, and we extrapolate side effect data from that. We base medications on weight. We do a lot of monitoring while our patients are on therapy. So no, we don't do escalation. We don't do induction. We do high efficacy medications right away.
Mm. And then what evidence supports the use of high efficacy DMTs as first line agents in pediatric MS, and how do long term safety profiles different from adults? We already.
We haven't gone into the evidence, but there's a lot of evidence of this. I'm blessed to have mentors who've actually done a lot of research on this. As far as most of the drugs that we have, I guess all of the drugs that we have, the mechanism of action, they work great on inflammation. That is essentially what we're good at. All the modifying disease therapy, that's all they do. We are not good at remyelination. We do not have anything for repair, which is why we cannot cure MS. We do not know how to redo our neurons, for lack of a better word. So why not use it at the time when we know it works best? And it works best at the time when the patients are hyperinflamed. Um, so there's data that has shown this. Not we have more experience data, like case studies. We have trials that have shown patients, how we have switched from the Pediatric MS Network, how we have switched patients, how hard our own practices have changed over the years, and seeing how we have been able to switch patients up from low efficacy therapies to high efficacy, and how we've prevented relapses. So there's real world data out there.
And then with pediatric patients in mind, having the disease for a long time, they're going through different stages of life. And for pediatric patients, that means going through hormonal changes as they get into teenage years and even as they eventually transition into adult care. How do those changes in the body impact
Yeah.
treatment?
Um, Not only treatment, but even diagnosis and presentation. At the time of diagnosis of MS, we know inflammation has started many years ago. By the time you're being diagnosed, you likely have had the disease for a number of years. Most patients are between ages of 18 to 45, and those are ages where they're postpubertal. If they're younger than 18, most patients present after 12. And it tends to happen after puberty in males and females. We know it affects females more, so there's a hormonal um, there's a hormonal, whether it's contribution or we don't correlation. There's a lot that influences the patient's disease course. We used to think of MS as different types. Now we think of MS as a continuum, or as one. Is it really truly relapsing? Is it progressive? Is it secondary progressive? Don't worry about that. My sense is, as the patient, the disease progresses, our therapies, we don't do this yet because everything we do is evidence-based, but we all know high efficacy drugs, and we talk, and there have been a few talks that have talked about this, to work at not specific, but there are prime ages that this is when we need to use these drugs. What we're not very good at is coming off of them, or at least de-escalating to what we consider lower efficacy. But there is a population of patients we know who are not as inflammatory, so maybe that's the group that they need. Now, is that dependent on hormonal changes? We do not know, but it is a lot to do with aging, which is why we have immunosenescence and MS being less inflammatory as we get older.
Mhm. And the age group that needs the higher efficacy drugs you're referring to, are those are the younger,
The younger.
because they're in that high inflammatory state, and then eventually they come off of it as they age because they're not as high inflammatory, or
Eventually, yes, but not all of us do that practice, right? After age 65, it's really hard to convince neurologist, physician, whoever, that there's still inflammation going on. Really, what we end up seeing are vascular diseases of the brain, so strokes and things like that. So at that point, I think that's the time to come off therapy completely. But after age 55, even if they still have MS, and I know they're older diagnosed MS patients, but do they really need to be on that high efficacy of a medication that comes with high side effect? Most of those tend to be infections, by the way, which are more prevalent the older you get, and more complications with other medications and other disease, which kids don't have that.
speaking of hormones, there's another very specific and hormonal time in some patients' lives, which is pregnancy and postpartum. So, how do pregnancy planning and postpartum impact DMT selection in women with MS transitioning from pediatric to adult care?
Yeah. So we've actually gotten really good data recently from the Minora and Sopranino studies. One of my I consider her one of my mentors, Dr. Riley Beauvais, and many other really docs who've spearheaded this for a long time. But now we actually have data to 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 guide our patients on. MS tends, as much as we know, tends to quiet down during pregnancy. And it does make sense, right? 50% of the fetus isn't you. Your immune system needs to make sure it doesn't, it stays quiet and doesn't do anything. It tends to be quite inflammatory again. The time of more at risk of relapses is right after birth. So patients, the time to, I'll backtrack by saying it's important for us to practice preventive care in MS, just as it is in any disease. The more managed the patient is as they're going into pregnancy, the more likely we are for them to come out of it and not have any relapses and be able to care for their child. So now, I don't know if this is just purely hormonal changes or the genetics or the physiology of pregnancy in itself. Our medications for the lower efficacy, which tends to be injectable, they're okay to be used during pregnancy. And this is where there is no FDA guidance, I would say. There are recommendations, but they differ between the same group of medications, between the FDA and the EMA, which regulatory bodies. The EMA is the European counterpart. So essentially, is this truly data driven? These got the recommendations. So by saying is the data that we have, we know we can treat our patients with high efficacy medications. First, it depends which one you're using. If you're using B cell therapies, we have a window to treat them before they get pregnant as they're going through pregnancy planning and at times during the first trimester. If we're using natalizumab, first and second trimester, and there are medications we try to avoid because of risk of rebound, something like fingolimod. When they're going right after the baby's born, then we have to think about lactation. And we really, really encourage our patients to breastfeed. It's good for the baby and the mom. So then, yes, do our medications cross the blood? First of all, do they cross the placenta? Some of them. Do they cross? At what level does the medication get into the breast milk? Some of them. Do they get into the patient's gut, into the baby's gut, and get absorbed? Not really. And if the relative infant dose is negligible, nothing that would affect the baby in the breast milk. So this information is available. LactMed, you will know exactly what to use. But as far as timing and what to do during pregnancy, I think we have data, but again, there's still a lot that, as a general neurologist, I would say, needs to learn.
So let's talk about transitional care and outcomes a little bit. What strategies optimize the transition from pediatric to adult MS care while maintaining treatment adherence and monitoring for secondary progression?
Yeah. So I would say, this is the goal of my career. It is what's true and dear to my heart. You know, I love kids. You don't know, but I do love kids because I care for them.
Yeah.
And there isn't really, as far as I know, we do lack the transition of care. Most adult trained neurologists feel very uncomfortable taking care of pediatric MS patients. And I would say probably the same, but most of us who treat pediatric patients can treat adult patients. Having said that, what does it look like? It shouldn't be so different. If the patient has been on a good medication, they can carry that over. Hopefully, in the next couple of years, we would have a cure and we would be telling a different story. As far as challenges, so one thing I guess we didn't talk about because we focused on the clinical part of MS. Um, these patients have lives,
Mm.
um, and there is during a time of their life when they're going to school, then they'll have careers, they'll have babies, then things change over the course of their lives. And so things come in. Um, their comorbidities that occur with MS, depression, fatigue, are very debilitating for our patients. And more life throws at you, the more we have to deal with that. So the care changes from just doing neurology to doing a bit more supportive care. And we do this with our patients as they age. And we do remind them that I take care of you as a whole, but really I do need help. I need you to see a psychologist. I also sometimes need them to see nutrition. But so going back to transitional care, what I'm hoping to do in my clinic is to be able to see patients of all ages, to be able to carry them over and go through their disease as they go through their life and grow with them. And I think what's lacking is I am specialized, and I know there are very few of us out there, but there are many physicians who I'm sure are a first line in seeing these patients, whether it's in the ER or hospitals, who do not know where to send them. So uh, please, please reach out, whether it's for by reaching out, I mean, there are bodies, there's National MS Society, where you can get information for pediatric MS care. There's the Pediatric MS Network Center of in the US. All this information is available on Google. And we're happy to come out there and educate the public
Mm.
about what we do.
So neurocognitive outcomes are
Mm.
very important. So how do neurocognitive outcomes in pediatric onset MS differ from adult onset disease, and what interventions mitigate kind of academic and occupational disability?
Oh, this is an area where there's a lot of data missing. Um, One thing we know for sure is just the length of time you have the disease. So, cognitive deficits occur in MS for many reasons. We think there's an underlying, first of all, there's atrophy. Forget the demyelination effect, the inflammatory effect. There's neurodegeneration. There's true neuronal death and dying, and like occurs over time. There's what we call smoldering inflammation that it's still there. It's inflammation that doesn't truly quiet down. And so we know that this is happening from early on. It's not you've had MS for a long period of time, then you get from relapses to having disability that's progressive, right? So since we know those relapses and this is happening from the beginning, like I mentioned earlier, our medications work very well on the inflammation part. They're not good at the neuronal death. So this is happening. So the earlier you've had the disease, the longer you're doing this. So having said that, I can say that cognitive effect. So by a lot of it is can get mitigated by therapy.
Mm-hmm.
Part of it because inflammation in itself would cause lesions, which over time would occupy the brain, and then you're losing brain mass. There's the neurodeath, which will also just over time cause disability. So having all of this just puts our patient at risk of having cognitive deficits earlier in life and more profound by the time they get to ages where they're now 45. And yes, they've had MS since they were 15 for 30 years compared to being diagnosed at 30. When you're 65, things are different. So we see the effect much sooner. And unfortunately, unless we're treating it better, and by better, I don't know that the therapies we have are covering it.
What are your hopes for the future of research and care?
Um,
Just a few. I'm sure there are many.
One is having research studies that are focused on. I know all research studies are focused on clinical care. There's a lot going on trying to cure MS. We want that. There's a lot going on the remyelination and all of that. We need clinical endpoints that can affect what we do in guidance, like the studies that we just talked about pregnancy and being able to have answers on what therapies we can use. We need to do more of those kind of studies. We also have to be doing our research in the right population. By right, I just mean inclusive. You're not going to find answers where you're not looking. And for many years, MS was the disease of Caucasian women of childbearing age. But no, it's not. And it has never been that. So to be able to get our patients involved in research, we have to design studies that they can see benefit from, and we need to get them to trust us enough that they're willing to be part of our studies, because we need them to understand we're studying so we can treat everyone better. And yes, there are many aspects of this disease that it's not just age, it's race, it's cultural too, it's ethnicity, because that does change our microbiome. That has a lot to do with our immune systems. There's a lot we don't know. There's room for growth.
Well, I'm looking forward to the future for sure.
Yeah, me too.
Thank you so much for joining us on MD Newsline podcast. It's been a pleasure.